This will be part 2 of the Neurolocalization lecture series where we will cover behavior, paroxysms, and mentation. Starting with behavior changes, this indicates a problem within the forebrain. This is by no means a complete list, but provides some of the more common examples of behavior changes associated with a forebrain localization. Certain behaviors, such as pacing and head pressing, are common to think about for brain disease. However, other behavior changes such as aggression, visual changes, and obsessive-compulsive disorders could also be related to a forebrain lesion, but it's also important to understand that some of these could be related to behavioral abnormalities without an intracranial lesion. This is an example of a dog with a behavior change where the patient will compulsively walk into a corner, becomes confused, and does not know how to get out of the corner, and then starts barking inappropriately. Once the patient is removed from the corner, he immediately compulsively walks to another corner and again displays the same abnormal behavior. To understand why something like head pressing occurs, we will go through this very superficially. In dogs, the red nucleus lives within the midbrain and is the main gate generator. The forebrain has influence over the red nucleus from motor cortex regions like the post-cruciate gyrus and suprasylvian gyrus. Additionally, deep within the brain lives the basal ganglion, which is also a key player in movement. When these higher centers communicate with the red nucleus, it leads to some degree of inhibition. Therefore, with a forebrain lesion, when the higher motor centers are compromised, this inhibition is no longer present and the red nucleus loses that inhibition, resulting in a compulsive type behavior to pace. With a large enough lesion, the prefrontal cortex could also be affected, which is important for cognition and decision-making. Therefore, if this pacing results in the patient getting stuck in a corner, the result is them pushing their head up against the wall, and without the cognition to understand how to get out of that situation, the patient appears to head press. Another common behavior change seen with a forebrain lesion is circling to the side of the lesion. This is that same patient that has the compulsive pacing but now is in a situation where they are not getting stuck in a corner. We see that this patient is circling to the right. So just by observation, we can say that this patient has a right-sided forebrain localization because with forebrain lesions, the animal will circle towards the side of the lesion. This relates back to decussation, where a lesion on the right is going to result in a lack of signal from the motor cortex to the red nucleus, resulting in increased activity from the red nucleus and subsequent increase in relative motor activity on the contralateral side of the lesion, thus pushing the animal towards the side of the lesion. This also applies to sensation as well. If the frontal cortex on the right is affected, then the patient doesn't know the left side of their world exists, so there is no need to turn left, resulting in the attention being drawn towards the right side of the body. Moving on from the behavior changes, we will now discuss spontaneous movements, seizures, and things that mimic seizures, abnormal episodes, or what I typically refer to as paroxysms. Just like with behavior changes, this is by no means a complete list, but will cover some of the most common paroxysms. These are spontaneous episodes, and the most common is a seizure, which would indicate forebrain disease, whether it is focal or generalized. Syncope is another common paroxysm and can commonly be mistaken for a seizure. Paroxysmal dyskinesias are movement disorders that are becoming more commonly recognized, such as with border terriers and their gluten sensitivity. Motor unit disease could also be classified as a paroxysm, although there is some debate as to if conditions, such as neuromyotonia, truly fit into this group. There is a condition known as paroxysmal cataplexy, which is different than narcolepsy, but for the sake of simplicity, we will classify narcolepsy into the paroxysms as well. And of course, the list goes on. The main point of this list is that there are a number of disorders that can mimic a seizure, and unfortunately a seizure, especially when focal, can mimic a lot of other disorders. For the sake of this lecture, just understand how complex differentiating the paroxysms can be. Most of the time, however, especially with seizures, it is straightforward, and we can confidently say if the patient had a seizure or not, especially with the presence of autonomic signs. This is a nice video to further drive home the point that it isn't always straightforward. As we ask ourselves what is wrong with this somnolent patient, the answer to this question is actually it is a paroxysm, and this patient is affected by an autoimmune form of narcolepsy. But that patient does serve as a nice segue into the question of, what is a mentation change? Starting from the bottom, a comatose patient has a heartbeat, They may or may not be breathing, and that is it. There is no response to any stimulation. Stuporous is any patient that might look comatose, but is able to be aroused by a strong stimulation, such as with a loud noise, strong odor, and pain, often by using hemostats to check for deep pain sensation in the toes. Obtunded is a vague term and simply means an abnormal response to stimulation and can be grouped as mild, moderate, or severe. Lethargy is a lack of energy or excitement, and there is some overlap between lethargy and obtundation. Then alert is going to be a normal patient. Recall that the ascending reticular activating system lives within the brainstem, largely the midbrain and pons, and sends rostral projections to the forebrain to help maintain alertness. With a large or diffuse forebrain lesion, the patient could become lethargic or obtunded. However, in order for a patient to become stuporous or comatose, a brainstem lesion needs to be present. It is possible for a less severe brainstem lesion to cause a patient to be obtunded, and it is possible for a forebrain lesion to cause increased intracranial pressure and lead to a patient being stuporous or comatose. Just like in this cat here, where there is a large extra-axial mass that is herniating from the rostral tentorium, caudally compressing midbrain, leading to stupor. Understanding the level of consciousness is hugely important for a number of different reasons. One is being able to appropriately calculate a modified Glasgow Coma Scale. This evaluates motor activity, brainstem reflexes, and, of course, level of consciousness. And the lower the score, the worse the prognosis, although this mainly applies to head trauma in animals after 48 hours of observation. That said, if you look at the bottom right, you will see comatose is only given a 1 as it is as bad as it gets in terms of consciousness. Here is that cat whose MRI we just looked at. This cat is not sedated or just coming out of anesthesia. This is just prior to the MRI. And hopefully you can appreciate there is some response when the cat is stimulated, but otherwise appears comatose. Therefore, this patient is stuporous but would be given a 3 for the modified Glasgow Coma Scale and would localize to the brainstem. To summarize, abnormal behavior from a neurologic abnormality are the result of a forebrain lesion. However, behavioral abnormalities are also possible for certain behaviors. And for certain behaviors, it is possible to localize the lesion as a left or right-sided forebrain. Paroxysms are generally straightforward but not always, and certain paroxysms such as seizures and narcolepsy localize to the forebrain as well. Mentation changes could indicate systemic disease or intracranial disease, and when intracranial, a diffuse forebrain disease could cause a patient to be obtunded, and a brainstem lesion could lead to stupor or coma. From Vet NeuroJar, keep those minds inspired, hearts light, and tails wagging.